Hello and welcome to the 27th Degree with Chris and Nancy. So this is episode 53, and today we're going to discuss atrial fibrillation with Dr. Nitesh Sood. And Dr. Sood is an electrophysiologist. So we're going to be discussing cardiac arrhythmias and electrophysiology, and specifically we're going to focus in on atrial fibrillation. Before we start our conversation, however, I want to thank our sponsor, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. As always, you can support the 27th Degree with Chris and Nancy by signing up as a patron. Go to patron.podbean.com/the27th Degree, or you can click on the link on our Facebook page. $5 a month gets you a shout out, exclusive content, and sneak peeks to upcoming shows. You can find the 27th Degree across social media, including Facebook, Instagram, and your favorite podcast platform. You can also subscribe to the 27 Degrees Consulting channel on YouTube. So let's get right into it. So Dr. Sood, thanks so much for being here. We really, really appreciate it. This is going to be a great conversation. First of all, tell us a little bit about yourself and basically what electrophysiology is so the audience can have a starting point.
Absolutely. So thank you for having me here. This is great. This is a great platform. And, in simple terms, electrophysiology is, or being an electrophysiologist is being the electrician for the heart. So I always tell patients I wasn't smart enough for the entire heart, so they made me the electrician.
That's a great way to look at it.
Yeah, but we are looking at just the electrical problems. We deal with all kinds of slow and fast heartbeats. So any type of rhythm problems, we put in pacemakers, defibrillators, devices for congestive heart failure. We do ablations for atrial fibrillation, for supraventricular tachycardia or SVT, take care of people who pass out, near passing out, all those things.
So how did you get into it? How did you become interested in electrophysiology?
It's just always fascinated me, even as a young man. I started collecting ECGs when I was a teenager. And
really?
So, yeah.
So you were collecting EKGs or ECGs as others were collecting, baseball cards.
Yeah.
Okay.
I needed a life as a teenager, but it's always something that's fascinated me. And then as I went through training, realized it's really something that's a passion of mine. And, it does take a long time to train. It's the longest subspecialty training within medicine you can do.
Oh.
So you're sort of you have to be a real nerd, I guess, to really get that far. But it's really fascinating, and it's been a great journey. I have been an electrophysiologist, so to say, for about 10 years now, and it's been very rewarding for me and hopefully for my patients.
So how many years after medical school did you train to become an electrophysiologist?
So it's a total of 8 years.
8 years. My goodness.
After medical school to become an electrophysiologist. Yeah.
So now when you say you're an electrophysiologist, that's not something that's in my vocabulary usually. Well, I'm going to go see my electrophysiologist.
Right.
So how do people connect with you? At what point,
Yeah, that's a good question. So essentially what happens is you have some sort of a cardiac problem and you see your primary care, then you get sent to a cardiologist. The cardiologist will manage your medications, get you sort of started. And then the cardiologist then sends you to an electrophysiologist for specialized management of electrical issues. Every once in a while, we have primary care doctors who send us patients directly if, they have something or they have a relationship with me previously. And, honestly, we have been getting patients who look us up online. And, smartwatches and smart devices are becoming so common with EKG capabilities. There's actually a shirt now that was presented at our annual meeting, which is just a regular T-shirt that can pick up A-Fib and do an EKG on you.
Really?
There are mattresses that do EKGs and pick up A-Fib as you're sleeping. So I think we're at the tip of the iceberg on how many people truly do have atrial fibrillation. And more when you sort of, end up with this EKG on your watch, on your smart device, on a cardio device, whatever you want to call it, or on your mattress. And you're like, well, what do we do next?
Yeah, can you imagine that? You're sleeping at 2:00 in the morning and your mattress will be talking to you. I'm picking up A-Fib.
Yeah. That technology exists as of today.
That's amazing.
Crazy.
Yeah.
So I know you deal with a lot of other arrhythmias and electrical issues in the heart other than atrial fibrillation. But atrial fibrillation is just such a a common problem.
It is.
Can we talk a little bit about the, how common it is?
Yeah, and I have some slides, and I know I'm not going to bore you guys. I promise you and your audience. But I think pictures sometimes speak 1,000 words. But this is a slide which hopefully you'll all have access to after our podcast here. But when somebody asks me, why me? Why do I have atrial fibrillation? I typically have the slide in my office, and I tell them the lifetime risk if you're over 50 of having atrial fibrillation is 1 in 3 right now. So it's really a very, very common phenomenon.
So Nancy, you 1 in 3 chance of getting A-Fib.
There's 3 of us here. It doesn't have to be me, buddy.
Well,
It
I'm
could be
fine.
you.
I'm fine. So it has to be one of you two here.
You know what?
Nancy's much older than I am.
Oh, stop. 10 months. All right.
And, of course, there's the usual risk factors that, we think about with atrial fibrillation, like diabetes, age, sleep apnea is a big one, including, just sort of getting older. Male sex is a big risk factor. But, one of the things that I tell people, I'll come back to these slides a little later, but there's another slide here. Exercise. And excessive exercise is also a risk factor.
Oh, I'm
Right.
fine then. Good. I'm safe.
Yeah.
Excellent.
So patients, we are seeing a lot of patients in their 40s and 50s, people who are marathon runners, triathlon runners, they are coming down with atrial fibrillation as well.
Why?
So the reason is, as you sort of work your heart,
catecholamines.
it probably gives you stress on the top chamber of your heart from all the blood flow. And that's where atrial fibrillation comes from. So athletes, people who have a slow heart rate at baseline, and the usual risk factors of age, obesity, sleep apnea, alcohol is a big one. On sort of finishing up the risk factor conversation, one of the things that is not a risk factor for A-Fib or does not cause atrial fibrillation if you have it is caffeine or coffee. One of the
Really? And you think
commonest
there would
misconceptions-
be a link?
It's one of the commonest misconceptions.
That is.
A-Fib always starts at rest. It always starts at your most restful state. So the common story is, I just had a meal, I was sitting on my couch, just relaxing, and boom, went to A-Fib. So, guys, there's no excuse not to exercise if you have A-Fib.
Right.
So why are people drinking decaf coffee because they feel like their heart races afterwards?
Well, atrial fibrillation-wise, there is absolutely no risk. Caffeine is protective against A-Fib.
But there are other, some people have, say, supraventricular
Yes.
tachycardia or something.
All other arrhythmias, caffeine can certainly precipitate it, yes, including PVCs, SVT, all of those things.
What does AFib feel like?
A-Fib is basically like a mouse jumping in your chest.
Yeah.
That's the commonest symptom of atrial fibrillation. However, there's a lot of people, so that common symptom of sort of this fluttering in the heart, chest pain, dizziness, it's really present in only about a quarter of the patients. About 3/4 of the patients are people who have so-called what's called asymptomatic atrial fibrillation.
I had one last week. Happens all the time.
Yeah, and we'll get into that. But before we get into the symptoms, I do want to show you this slide, which sort of opened my eyes on should we take this seriously? Because you have A-Fib, people go to gym and they work out and they still have a decent life. But this is a slide, an epidemiology slide done at Duke by a good friend of mine, Jonathan Piccini, and he looked at survival in Medicare patients. So these are people over 65 who get admitted to the hospital. So these are not people who walk into your office. I'll show you what the data on those patients is as well. But if you get admitted to the hospital as of today and you have atrial fibrillation, your risk of dying at 5 years is 10 times as much as breast cancer. You see breast cancer on the bottom there, and you have survival almost the same as cervical cancer.
Why?
Because atrial fibrillation causes, next slide, it's a perfect segue into my next one. It causes acute MI, it causes stroke, it causes heart failure, and all of these things lead to death in about 50% of these patients.
Is that untreated?
That's despite treatment.
Really?
Yeah. So,
Why?
because a lot of times people come in and they're not treated aggressively for atrial fibrillation. They're told, oh, you have an irregular heartbeat. Here's a blood thinner. Here's some metoprolol. Go home. You can live in A-Fib. you're old, 70 years old, you'll be fine. And it's a benign diagnosis. And that's why these people end up with, significant mortality at 5 years.
Yeah. I think a lot of people don't know that. I mean, I think that's really interesting
I don't
information.
even want to let that go yet because that's like mind blowing to me. So then shouldn't there be education out there that has to be treated aggressively?
Absolutely. And that's one of the, I think, Achilles heel of atrial fibrillation is not just patients, but, us as physicians as well. Atrial fibrillation, I always joke is, or, my wife tells me, who's a physician, she's like, one of the most annoying things, to treat because you really don't know what symptom is the right symptom. What are you treating? And, I'll show you a couple of these slides to sort of talk about these symptoms. This is a sort of registry done across the world in 26 countries looking at 10,000 patients. And there are basically 3 types of A-Fib as we talk about. There is the A-Fib that goes in and out of A-Fib. So it comes and goes, all what's called paroxysmal A-Fib. And those patients have symptoms of, shortness of breath, chest pain, palpitations. The second are people who are in A-Fib all the time. So they are living with A-Fib, typically all the time. And then there are patients that are called permanent, meaning we've tried everything we can and there's nothing we can do, so they just are sort of succumb to A-Fib. So if you look at these persistent versus paroxysmal versus permanent patients, you see that most patients are actually non-paroxysmal, meaning they are the ones who are living with A-Fib, so who are not acutely symptomatic. But if you looked at medications and medication adjustment, a lot of these, about 80% who are so-called living with A-Fib, needed some sort of a medication adjustment to make them feel better. So it turns out you are not asymptomatic. This is not just somebody who's asymptomatic living in A-Fib. They're constantly seeking medical attention from their doctors, from urgent care. They're just not sick enough to be admitted to the hospital.
So a couple of things wrong with that scenario then. It's like we're using resources that we shouldn't use, in healthcare to treat A-Fib via ERs and what have you, instead of aggressively treating these patients. And 2, quality of life.
Yep, quality of life is significantly impaired in these patients. So coming to the second half, of these 3/4 of patients who don't have these acute symptoms, what happens is they come to you, they're like, we just feel tired. I used to be able to walk up 2 flights of stairs, and now I feel I'm getting short of breath. Am I just old? Am I just getting old? And a lot of times, they are also getting old. But, I ask them, well, could you do this 6 months ago? And if the answer is yes, well, nobody gets old in 6 months. The problem is, as this slowly progresses, we see them in their 10 years down the line. But now they can't even walk a block and they're short of breath. And at that time, you've been in AFib for 10, 15 years, and it becomes a very difficult problem to treat. So that is sort of the Achilles heel of AFib, that a lot of these patients, as I said, 3/4 of these patients are not acutely symptomatic. So what really needs to happen is that index visit with your doctor or the hospital, as we discussed, that's when you need to make an intervention.
Right.
So what about these? So, I'm sorry, I'm sort of, stealing your questions, but
No, that's great.
you can see I feel very strongly. I can talk about AFib forever. But what is the data? Because, in cardiology, in medicine, it's always about not what I feel or what you feel or what, the other person feels, but what happens to the general population when you apply these rules.
Right.
What is the data on this stuff? So I won't bore you too much, but I'll show you 2 quick studies. And one of these is called the East AF-NET, or the Early Rhythm Control Study, that was published a couple of years ago in the best journal in medicine, the New England Journal of Medicine. And what this is looking at that asymptomatic patient that Dr. Jonkers you just described, who saw you in the office and said, may not even have known they were in AFib. Do you see them as often?
Yeah, sometimes what happens is I see them for an annual evaluation and I notice their pulse is irregular, or I do an EKG because they have hypertension, so it's an annual EKG or whatnot, and I just pick it up. And that's not uncommon that happens. Yeah.
So, then the question becomes, in that person who's relatively asymptomatic. So let's say, you walk into your doctor's office and you still go to the gym 3 times a week and so on and so forth, or you're not significantly limited, or at least that's what you think. So this study was done for that person. So they said, well, rather than just leaving them on routine medications and a blood thinner, what if we brought them in and treated them aggressively, like we discussed earlier? And this study was stopped at 2 years because there was mortality benefit, meaning that patients who were in the usual arm died more than people who were aggressively treated.
Right. And the usual
So
arm
is that
was
what we're looking at on this graph? It's
yeah,
like the mortality, right?
Yes, you're looking at the death rates, and in the orange is the usual care, in the blue is the early rhythm control arm. And not early rhythm control doesn't mean everybody gets a cardiac procedure or something fancy or something invasive. All we did was we brought them in and we cardioverted them, which means we just shocked the heart to reset the heart and gave them a medication to keep them in normal rhythm. The key is normal rhythm. And about 20% of these patients also got ablation. So, but majority of them got a non-invasive procedure to keep normal rhythm. And as I said, this study was stopped earlier because there was mortality benefit.
So it just kind of, that cardioversion just kind of is like a reset button.
Yeah, it's just a reset button. As I joked, there's all these short circuits sort of dancing around in the heart that have developed due to age, high blood pressure, sleep apnea, so on and so forth. And when you shock somebody, or all you do is you stun them. So you stun them and they quieten down, and then the normal system takes over. And when that happens, we give them medications to keep them quiescent.
How come that works? And this is probably a silly question, but if your body has gone into like A-Fib mode, how come, like, you cardiovert, but does that last, or does it just go
In
back
some people, it
into...
can last for a year or two.
Okay.
It all depends how many short circuits you have. Just like any infection, the body is made to fight something that's not normal.
Okay.
And normal sinus rhythm is normal for the body. So the body will fight it as much as it can. And in a lot of patients, first time around, if it's new A-Fib, a cardioversion with some medication can last them, a couple of years,
Okay.
which is a long time. And then as these short circuits get stronger and proliferate, then A-Fib can come back. But a lot of times, it's also nice to see and gauge the difference. I have a lot of patients who come to me and say, doc, I feel fine. I've been doing all my usual activities. I go grocery shopping, we go for walks. And, we discuss, is it really worth doing anything? And I say, well, let's not do any major procedures, but let's just reset your heart.
Right.
And see how you feel. It's a simple, quick thing. You come in within a half an hour, you're home. And, invariably, they will come back to me at a few weeks and say, I just didn't realize.
I think that's a
common.
big part of it.
Yeah.
I see this all the time with other diagnoses. For example, one of the common things we see are patients who have cataracts, and we do preoperative evaluations for them. And, their vision is off, but they don't think it's that bad. And then they come back after, like, oh my God, I didn't realize how bad my vision was. So I think it's a similar thing. I mean, we adapt to these issues to some extent, and we don't realize how it's affecting our physiology.
Agreed. Human body has the most amazing capability to adapt. And, that happens with atrial fibrillation, the non-paroxysmal, meaning the non-in and out type, all the time. So, my plea to everybody who's listening, has friends, A-Fib is not a normal thing. It's not normal. That's not how God made us. That's not, how the heart is supposed to be. So normal rhythm always benefits somebody. Of course, we look at risk-benefit ratio for every patient.
Of course.
But, this was a study done on all comers, just people who showed up with so-called no symptoms, and they lived longer.
So if I'm someone that's listening right now to this podcast, and I've been on medication and anticoagulants and what have you for
Rate control and blood thinners,
right. I mean, what should I question my primary and say, hey, I feel okay, but I listened to this guy who said maybe I could feel better.
Yeah, I'm not sure it's as much questioning as far as advocating. I think what happens a lot of times is it's easier answer and an easier question for patients to say, no, we're feeling fine. because nobody likes going to the doctors, right?
Right.
We barely like coming to work in a hospital, right? Nobody likes coming to the hospital.
Right.
So, it's an easier, it's like, men with hypertension. This, I can give you my story. I kept having borderline hypertension till my wife put her foot down and said, you got to get an Omra and blood pressure cuff and show me your blood pressures. And, lo and behold, I'm on a antihypertensive medication now. And it's denial.
Yeah.
And sometimes you just have to advocate for yourself. And if you really look back into when you went into A-Fib, you will find that there has been a decline. You may be taking more naps. Maybe you were climbing 2 flights of stairs. Now you stop on the landing, between. And
Right.
even otherwise, there's mortality benefits. So as long as there's no other major, problems going on, what's the harm in a trial of normal rhythm and see how you feel?
It's amazing to me that some people actually don't feel symptomatic, because if you look at, so the atria, when it contracts, right? My understanding from, basically physiology, it's like maybe contributes to about 20% of cardiac output, right?
Yes.
That's a lot. So if you lose 20% of your cardiac output, you would think everyone would be symptomatic with that. It's remarkable that more people are not.
Yeah, I think what we feel, again, a slightly biased feel because, I do A-Fib all day in, day out, is that everybody is symptomatic. They just don't realize. There's sort of different degrees of symptoms. I feel like a lot of us are in denial till we get sick enough to come to the hospital.
We adapt, right? We work around it.
Absolutely.
We find other ways to do things we normally did differently.
Yeah. And so anyways, that's, sort of my, passionate plea on the so-called asymptomatic A-Fib. And, of course, an ablation is sort of the next sort of frontier on management for atrial fibrillation after treating symptoms.
So can you describe what an ablation is and just define it a little bit?
Yeah. So, an ablation in simple terms is sort of, taking away or destroying these short circuits. Now, there's many ways to do it. There's the freezing technique, which, we are sort of known for. It's called cryoablation. There is a burning technique called radiofrequency ablation. There's a new technology called pulsed field ablation. And depending on how much time we have, we can get into the details. And those are just basically small electrical currents that are sent into the heart. And, we are very proud because the clinical study just finished a few months ago, and this technology should be approved for general use hopefully next summer. And we at Charlton, we were the first ones in the world to do a clinical study patient. Yeah, it was
impressive.
It was one of those truly lucky incidences. We were part of the clinical study, the only hospital chosen in the entire state.
Great.
Despite some of big name hospitals.
Of course.
For this particular study. And we ended up doing the first case in the clinical study, which was it's a worldwide study. It's called the pivotal study. And so we've had a lot of experience with newer technologies for A-Fib ablation. And, just talking about ablation in general, it's something we do sort of minimally invasively. We go through the vein of the leg, just like a catheterization. We go up in the heart. We find these electrical short circuits that are causing the problem, and we are able to cauterize them or freeze them, so to say. So then comes down to, well, should you get an ablation, right? That's the next question everybody asks. When should I get an ablation? Should I wait for my medications to fail? Should I do it when we have the first episode of A-Fib, second episode of A-Fib, or if I'm on A-Fib for a year, 2 years? So one of the, good things about cardiology is any question you ask, we do a study on it. We love doing studies.
You guys have great names for all your studies.
I know.
They always have these great mnemonics.
Yeah. So I'll tell you another great name is called Stop AF First.
Okay.
So this is a study that, again, we were very lucky to be part of a big series of hospitals, which this study was led by Cleveland Clinic.
Great.
And we were part of this study. It's called Stop AF First. Encourage people to sort of Google it, look it up. And, I was proud to be the third author on this paper, and we were the highest recruiters in the world for this study.
That's great.
Which was, given that places like the Mayo Clinic, Cleveland Clinic, all the big name hospitals are part of the study, as you'll see with the authorship. We were very proud to be a significant contributor to this study.
I think we live in a great area for medical care. We're absolutely blessed.
Yeah, and the nice thing also is if you come to me, it's only me who will ever touch you. Same thing for my partners or everybody else in the area. As for you, I mean, when somebody comes to see you, it's you they are seeing. You who's calling them after. It's sort of FaceTime with you. So, but anyways, this study looked at trying to give medications versus doing an ablation early on in the disease process.
Can I ask you one question quickly? Does insurance cover this?
Absolutely.
It does. They won't make you do some other non-invasive therapies first.
No. So this study is what changed that whole concept. So prior to this, you had to fail multiple drugs,
right?
And then you would be, covered, so to say, for ablation. And what would happen is you would have multiple ER visits, and the disease would progress.
Right.
So the hypothesis or the sort of theory behind this was, what if we stop the disease process early?
Yes.
Which makes logical sense. But, again, these procedures are invasive, they're expensive. So it's not just the coverage, but also safety.
Yeah.
So this study was done where if you fail metoprolol, like the simple medication, and you have A-Fib again, what should you do? Should you get more advanced medications or multiple medications, or should you go straight to ablation? And what they found was that it was twice as effective to undergo ablation up front. And the complication rates were very low. They were 1% or lower.
So when you say do ablation up front, what's that time frame?
So within the first few years or of having atrial fibrillation or having your second or third episode, not the first one. And, so this led the FDA to approve cryoablation as first-line therapy in these patients, and which is what led to the insurance is now approving it.
These slides are amazing.
Oh, thank you. But, so there's, and that's why I always tell people, medicine, no matter which field of medicine you're in, it should not be, a decision should not be biased based on one person's opinion. It should be something you can apply to the general population.
Yeah.
Is it applicable to somebody here in Fall River versus somebody in Boston versus somebody in California versus somebody in London? And the answer is, if there is data on it, then, and it's true across boundaries and people, then, there must be some meat to it.
Right.
So this is what led to, cryoablation sort of being, considered as a first-line therapy. And so that's where we are in the ablation realm.
So, Dr. Sood, when someone has an ablation for A-Fib, do they stay on any kind of medications afterwards?
Yeah, so they stay on minimal medications for 3 months.
Okay.
And depending on their stroke risk, which we'll talk about later, they can come off their advanced medications, which are called antiarrhythmic medications, and sometimes even blood thinners. Although I do tell people that coming off blood thinners is not the goal of the procedure. The goal of the procedure is to improve symptoms of atrial fibrillation. And it's a bonus if you're able to come off blood thinners. There are other procedures we do for people who cannot take blood thinners, and we'll discuss that at the end.
But that's a big benefit if you can get off the blood thinner, even though it's not the goal per se. I mean, I have so many older patients that are fall risks and whatnot who, they fall and they hit their head, and that can be life-changing.
Yep. And,
blood thinner.
The issue is if somebody had seen and done an ablation early, like any disease, let's say there was an ablation for diabetes, it would make sense to do it earlier than later, and we are
the damage. Yeah.
We are getting aggressive about all these therapies because A-Fib is a progressive disease. There's this concept in A-Fib, it's called A-Fib begets A-Fib. So each time you have an episode of A-Fib, those short circuits create new friends. And then those friends create other friends. So that's why the common description is, I had A-Fib 5 years ago, and then I was just fine for like 3 years on nothing. And then now suddenly I'm having A-Fib again. What did I do? Did something change? Am I eating something wrong? Am I doing something wrong? And the answer is no. It's just that now you have enough. The water sort of boiled to a point where it's sort of spilling over.
Right.
So what I'm hearing is that, and just correct me if this is wrong, but for the audience's perspective, the longer one might wait to treat it with a procedure such as what you're describing, the less effective it could even be.
Yes. But so then then the question becomes, what if it's been too long? What if now, let's say somebody's out there who's listening to this, and like, shucks, this was me 5 years ago. Now what do? I'm in A-Fib all the time. I have some swelling in my legs, or I feel short of breath. My doctor says I have congestive heart failure. I am on, diuretic pills, like water pills, like Lasix or furosemide. What about me? So, well, it's a study for that too.
Okay.
So, what happens to these rhythm control beyond the acute symptoms of patients who are, acutely symptomatic, who are now a bit further on and, have congestive heart failure? And the question always is, what is causing? Is it my heart rate that is fast, or can I be so-called controlled heart rate, meaning 60s to 80s, but still have heart failure symptoms and A-Fib symptoms? And the answer is that it doesn't have to be a fast heart rate per se. You can have a heart rate that's so-called controlled, meaning 60 to 70 or 80, which can still give rise to symptoms. And again, there's two studies I like to point out. One is this famous study called Castle A-Fib study, which was done in heart failure patients, again published in New England Journal of Medicine. And again, showing if you have congestive heart failure and a diagnosis of A-Fib, you have mortality, meaning you would die less if you had ablative therapy or ablation therapy versus medical therapy. So again, the question always becomes, and again, this is not for every single person, not if you're maybe 90 years of age, but it at least behooves you to explore this.
Right.
If there's mortality benefit data that you might live longer with coming back into rhythm with an ablation therapy, then it makes sense to at least explore if you're a candidate or not.
So how do you catch the majority of A-Fib to get that initial diagnosis? Like if you're doing an EKG and that might not be the moment that you're experiencing it.
Yeah. So, an EKG only gives you 6 seconds of your life, right? And a lot of patients who sort of show up to the office, to your office, who are in A-Fib, they went through the paroxysmal episodes, meaning going in and they just were not symptomatic enough to realize that.
Yeah.
So I think that's where these smart devices will change a lot. So the Apple Watch, if you wear this, or a Samsung watch, or the Garmin watch, or whatever new watch, a Fitbit, the newer generation Fitbit, they are constantly in the background looking at your heartbeat. And even if you have an episode, I have this all the time. Patients come to me and I was feeling fine, and I heard a beep on my watch and it said irregular heartbeat or fast heartbeat. And I did an EKG on the watch, which you can do, which you can actually email it to us through Epic or any EMR, or show it to me when you come to my office. And lo and behold, my watch told me I was in atrial fibrillation. Now, these patients could have had a stroke. And that's why there are so many people who have what's called cryptogenic stroke, meaning stroke of unknown origin. And we do tests on them after, put monitors on them, and they've been having A-Fib, they don't realize.
It's actually very common.
It's so common, right? It's so common. And it's that's where I think these watches and smart devices are really going to change the paradigm of management, and really, hopefully help patients.
Yeah. And I think what's scary about the strokes that are associated with AFib, these are sometimes very large strokes. They're not like, they're not like these tiny little strokes that people have. I mean, usually when there's an embolic event, a piece of, material that goes up to the brain from AFib, it can be really devastating.
It can be, yes.
Can we talk a little bit more about that physiology with like AFib, the relationship between AFib and stroke? So what exactly happens that there's
sure.
that correlation?
We'll just sort of jump a few slides here and go to some stroke slides. Can come back here. So this is AFib and stroke. So the first thing, for all the audiences and people listening, is what is the risk of stroke? There is this risk score that's called the CHA2DS2-VASc score, which looks into how old you are, male versus female sex, if you have congestive heart failure, vascular disease, and you as I said, you have these slides, or you can just go on Google and say, what's my CHA2DS2-VASc score? Put in your history and boom, you'll have your score. Just to assess, so if you're more than 2 in men and 3 in women, you should be on a blood thinner. Yeah. But what happens? You have to answer your question, what is the reason for having stroke? So first of all, this is sort of the as many people have A-Fib, and if you have A-Fib, there's 5 times higher risk of stroke in A-Fib versus a normal person. So what does happen is there is this area or outpouching that you see on the right top. This is what we call an echo image, meaning an ultrasound image of the left top chamber. And at about, let's say, 6 o'clock, you see this little triangle-shaped outpouching. That's called the left atrial or the left top chamber appendage. And the way I describe this whole scenario to patients is it's like the appendix of the heart. So, when the surgeon does an open heart surgery, for some example, let's say, for whatever reason, for bypass or your valve, he or she will just cut this thing off. It serves no purpose. It's the embryonic remnant of where the left top chamber becomes the left top chamber when we are, in our mothers. So this is sort of like a leftover remnant, and it is sort of a narrow structure, as you can see. And when your heart's beating like this, the left top chamber, blood's flowing smoothly. When it starts doing this, which is what atrial fibrillation is, blood starts swirling around, sort of getting what we call stasis or sort of standing because it's not being pumped as vigorously. And that is fine if you're in a big circle on a big chamber, but if you're in a tiny area and the blood's sort of circulating here, if you see on the bottom there's a little big sort of globule, and that's what a clot looks like. So blood sort of just circulates in this small, narrow channel, like any other, narrow channel or isthmus, as we call it, or the Panama Canal, right? That's where you get the ship that gets blocked because it's like turned sideways. So that's where blood gets blocked. And when you go from this to this, that goes right out into the heart, the left bottom chamber, and the first artery from the heart goes to the brain, which is why we end up with strokes. So that's the reason for having strokes in people with atrial fibrillation. So, on the flip side, to thin blood in that one tiny area of the heart, you have to thin the entire body's blood.
Right.
Yeah, and that's not a benign thing all the time.
That's not a benign thing. There's, there's lots of risk with being on blood thinners, bleeding, the obvious one. But that's what we have to do, and there are other options which we can discuss. But coming back to sort of what ablation is, ablation essentially for people who are sort of interested is two-step process. What is an ablation? What do we do? And this is going to get a little hopefully fancy, but I designed this figure. It took me all weekend, so I'm really proud of it.
That's great.
And what you see here is a sort of cut out specimen of the heart. And where you see those things flashing is what's called the pulmonary vein or the lung vein. So that's the vein that brings blood from the lungs that we sort of has oxygen and comes it into the left top chamber, which is the left atrium, right? So when you have initial A-Fib, which is sort of in and out of A-Fib, we have what's called triggers, meaning there's short circuits inside those veins at the junction of that vein and the left atrium. So it's actually a misconception that initial A-Fib comes from the heart. It doesn't. It comes from these veins. So when we go in, our initial step of early A-Fib ablation is to isolate those veins electrically from the heart. And that's why you might have heard the procedure is called pulmonary vein isolation or electrical isolation of the pulmonary veins or the lung veins from the heart. But when A-Fib spreads, it also spreads to the entire left top chamber, as you see in that circular motion. And then you see all those sort of round structures behind it. The one that has some serrations or corrugations is the food pipe or the esophagus. The one behind it, the big one, is the aorta or the main artery of the heart. So you can see that when you spread from those peripheral areas to the center of the left top chamber, and if you try to cauterize or ablate all those areas, then you start getting into these areas where now you're close to some important structures of the heart. So you have to be careful on how much to ablate, how to ablate, and what that happens.
How do you know where the short circuit is, though? If you're in the the pulmonary vein,
Right.
how do you know that this is the area I need to
That's a great
ablate?
question. So we sort of do what's called a three-dimensional mapping. So this is an example of that, and you can see these structures that are coming into the heart. Those are the pulmonary veins, and that is so a patient's pulmonary vein taken with permission. So we create a three-dimensional model of the heart. And, as my friends joke, this is like a little boy's dream come true. It's like you're playing a video game, really. So we are operating in the heart, but we create these three-dimensional models, and we can identify normal versus abnormal electrical current on these 3D models. And then what you do is you create this area of electrical burning. So this is what's called a radio frequency ablation around these electrical short circuits, and you isolate them from the left top chamber. This is an inside view. To make it a little bit simpler is this outside view. So again, this is a three-dimensional reconstruction of the left top chamber, and inside and outside view. And as you see here, those two things that are coming in are these two veins coming into the top chamber of the heart. And those red dots and that little catheter you see with the green on it is sort of the traditional radio frequency catheter, which we have used to create, each dot is a burn. So we create what's called a round circle of burn around those 4 veins, and electrically isolate the veins. But
so you're really isolating those short circuits from the remainder of
Yes.
the heart, from the heart. Okay, that makes a lot of sense, actually.
yeah.
Dr. Sood, how do you know what type of ablation you're going to do?
Yeah, so that's a great question. I feel like I almost sent you all my questions because you're asking me all my slide questions. But for patients who are paroxysmal or who are early on, they will either get a freezing or a burning technique depending on which person and what institution they go to.
Do you know that before you go in?
Yes, yeah. For the most part, based on patient's history and some tests
Okay.
we run, we are able to figure that out.
Okay.
So, the cryoablation or the sort of freezing technique is similar. You are electrically isolating those veins, rather than doing burning. You take this balloon that you see here and you inject it with nitrous oxide.
Okay.
And the front surface of the balloon gets completely cool.
Okay.
So you see that there's that dye-like thing coming, and the balloon is sort of opposed against that vein. But rather than burning all around with the pinpoint catheter, now I've taken a balloon and just put it there, inflated it with nitrous oxide, and in one shot, you're able to isolate the whole vein.
Does one procedure feel different to the patient than the other one?
Yes. So most patients will have a lot less post-operative inflammation, pain, discomfort with the freezing, just like you would if you get,
Right.
freeze burn versus a regular burn. And, the other issue, so this is just a study that showed it's beneficial, but the problem is, as you see with any technique, you see this sort of burning. So this is the vein that's coming, that's called the LPV, and you see those thin pockets of tissue. So, and you can see those fibers that are going into those veins, which is what we're trying to isolate. And the other one is this, what's called the LA is that left top chamber, and the ESO is the esophagus or the food pipe. You can see how close that is to the back wall of the heart,
Right.
right? So you get seeing those veins that are far away from it. So no matter if you burn or on the right image, the RS, RM, RI, those are the veins on the right side. And if you cauterize or freeze there, you are further away from the food pipe.
Yeah.
But if you come closer and closer to the back wall, when you're in A-Fib all the time, the persistent patients,
Right.
that's when you get so close to that descending aorta or the main artery of the heart and the food pipe. I mean, if you saw this image, you'd be like, oh my God, I can't believe I'm going to have this procedure done, right? It's so close if you look at, an anatomical specimen. So for the most part, pulmonary vein isolation or electrical isolation of the lung veins works extremely well for the people who are early on in the disease process, meaning first 6 months of A-Fib, or people who've only had a few episodes and are still paroxysmal, who have not been in A-Fib all the time. Hence, again, why we really, sort of want to send this message that it's not just the outcome of the procedure, but the risk of the procedure is also much lower. Right? If you're just getting the peripheral part of the left atrium done, and it's a great question to ask your doctor when you go to them for an ablation. Well, what am I going to get done? Am I going to get just the veins, or are you going to ablate my back wall of the left top chamber? And how are you going to mitigate the risks that come along with these procedures? So the reason for some of these slides, which I know, are a little bit more advanced than just a general discussion about A-Fib and risks and, symptoms and so on and so forth, is because I really want patients to ask, educated questions, and sorry for that little pitch, but we actually have our own small website and app called Club A-Fib. It's called clubafib.com, very cliche, welcome to the club, not the club you want to belong to. But we've sort of created an app that links to your smartwatch.
That's great.
And creates a graphical representation of how much A-Fib you're having. It also has all these articles and some videos on A-Fib, what ablation is, so on and so forth. So as a resource, for your listeners, if they're interested in details, that's another platform to look into. It's a free platform.
So what was it again? Club A-Fib?
Club A-Fib, yeah. And so anyways, what happens to these patients then if they are in persistent A-Fib? So for those patients who need back wall ablation as well, we have a special procedure that's called a hybrid A-Fib ablation. So because that back wall is very close to the heart, rather than just cauterizing directly against the back wall, we combined with one of the heart surgeons here, and they cauterize the back wall from outside the heart. So what they're doing is they're going to just a small scope. It's not open heart surgery by any means, but they go through a small scope here, go behind the heart, and cauterize the back wall from outside in. And when they do that, they are directing energy away from the esophagus or away from the back wall versus us doing it from inside and pushing it towards, right?
That makes sense.
And again, we've had this program now for about 7-8 years, and we are one of the busiest programs in the state. We actually train other doctors from around the country who come see us do this procedure, and this is called a hybrid procedure. So what happens is a hybrid AF ablation. Again, there's many resources online, but you can look at the procedure, but it's done in a sort of a combined procedure where the surgeon does the back wall, we do the inside. It's all one procedure for the patient. But for people who have been in AFib now for a few years, and they have congestive heart failure, and after all this discussion about early ablation and the periphery versus the back wall, there are options for these patients. So certainly, we have come a long way in the world of atrial fibrillation. And I'll finish with just one last.
So this would be done less commonly in someone with newer onset atrial
Yes, this is meant for advanced AFib patients. Those patients who've had multiple ablations, have failed before. We do this very, very commonly. Okay. So I'll finish with one last fancy picture. My friends always joke, electrophysiologists love fancy, pretty pictures. And again, this is that patient and that case I was telling you about, which was the first case in the world of what's called pulsed field. And again, I want listeners to sort of just, if you have AFib, and if that's why you're listening to this podcast, and you are thinking about an ablation, or you have, you might be a candidate in the future, it's important to know all these things, because it's different to just sign up for a procedure when there's 5 different types of this procedure. So pulse field ablation is this procedure. As you can see here, you're looking at the same left atrium on the left bottom with all those colors. Those are all the abnormal short circuits. You asked how we define what normal abnormal is. So our maps, or these 3D models we create, not only create what's called the geo or a geometry of the heart or the left top chamber, but they also create these colors, which are representation of the electrical signals themselves in your heart. So in this case, you see that the purple is normal and the reds and all the other colors are abnormal. So in this case, with the patient with advanced AFib, you can see that those purples are not just those reds are not just limited to the veins, which are in the corners, those 4 little things, but they're spreading into the back wall. See, the purple is a very small part of that heart. It's all mostly red, white, so on and so forth. It's all intermingled. And pulse field ablation is what we did on the top, which is that circular catheter. Now, the advantage of this technique is that it causes very little collateral damage. So rather than burning or freezing, this just sends a little 2-second impulse.
What am I looking at? It looks like spaghetti.
Yeah, so that's the catheter that was used to deliver energy. So each round circle is each application of energy on the top.
Okay.
Right? So it says PFA, 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 that's pulse field ablation. So, and then on the right bottom, you see the gray.
Yeah.
So you go from all those short circuits, and when we do the same electrical map after we are done ablating, you're all electrically silent, which is what's gray. And as I said, this advantage of this technique is that it causes very little collateral damage. So this is coming down the pike. South Coast, and our local areas will be the first in the country to have access to this within the next year or so.
That's great.
So again, something to look forward to as an A-Fib patient.
How does that affect the contractility of the atrium? Does it affect the actual muscle function?
Yeah, so studies have shown that it doesn't affect the muscular function because you're looking at just the electrical signals. The other nice thing is that most of the function, as you said, I think it's a great question, comes from the front portion of the heart. So it comes from the top and the front of the heart, not from the back wall of the heart.
Okay.
The back wall just sort of hangs, steady and sort of static in between what we call reflections of the heart or pericardial reflections, which is why they also generate a lot more electrical short circuits.
Dr. Sood, what would be the contraindications of a procedure like this?
So the contraindications of any ablative therapy really are that you are too sick to undergo the procedure,
Okay.
or the procedure is too, your A-Fib is so advanced that no matter what procedure you do, it will not work.
Okay.
So the reality of the situation is that almost everybody is a candidate for some sort of ablation. The problem is, if you look at data across the country, and this is not just here in our local area, but only about 10% of people who should get an ablation ever actually get referred for an ablation.
It's low.
So it's very low, and it's very underpenetrated. We are lucky to have a very personal relationship here with our primary care providers, our cardiologists, and to give you an example, when I started here 9 years ago, which is not that long ago, we were 3 of us, and the goal at the program was to do 25 A-Fib ablations. That's how little number of ablations were being done here
In what time period?
in 1 year.
Oh.
So that was the goal of a program, to do 25 to 30 ablations, because they were doing none. And last year I did 200.
Oh, thank God.
So, and there's 3 of us who are all equally busy. So, it just goes to show how underpenetrated our area was in patients. So unless you had contacts, or you could drive to Boston and, find parking, good luck with that. You would never ever be referred for an ablation procedure.
I think there was always a sense too that if you were on like you had mentioned, if you were on a blood thinner and a medication for heart rate control, you were fine.
Good to go.
Yeah.
And clearly that's not the issue. I mean, clearly patients have an increased mortality. They die quicker. But I don't know if that message is out there. It's getting out there now.
It is, and thank you for you guys to do that. But it has evolved over the years.
It's evolved, and more studies have come out, and more education and whatnot. So, yeah, it's fascinating. How long does a procedure take like this?
So most ablations, in the olden days, were done with patients awake, which is quite uncomfortable, and also would take 4 to 6 hours.
Okay.
Now the standard procedure is about 90 minutes to 2 hours.
Okay.
Oh, wow.
And it's one overnight, or we are sending patients home the same day.
That's great.
So even as patient comfort and tolerance, it's come a long way.
And are you putting me out, or am I still awake?
Completely out. Yes. You come in, you say hello, then you go to sleep and you wake up and say hello.
That's great.
I like
Do
that.
people feel better immediately, or does it take some time for them to feel
Mostly
better?
it's very immediate. So recovery from an ablation procedure is about, as I said, one overnight in the hospital. And we ask you not to do something heavy exercise for 7 to 10 days post. And after that, you're back to sort of, normal routine.
That's amazing.
So do you have a story that you can share about us, about someone's quality of life that was so
Just a great story that
Yeah,
really...
so this actually was a story that was covered on Facebook by the South Coast, website. So you can find it on the South Coast page. But this was a lady who saw me for after having had 4 ablations elsewhere. And she had sort of, the older technique, and she, super nice lady, grandkids in her 70s, and was having A-Fib every day. And she just couldn't go anywhere. She had no quality of life. And she underwent a 5th procedure, which is, but thankfully she had the advanced procedure that we do, as you'll see. And it's almost been a year now. And she's out with her friends. She picks up her grandkids.
Oh my God!
It's
Totally
really
different life.
life-changing.
Life-changing.
Yeah,
And,
it's amazing.
many stories. I mean, I've had friends who are, patients who have become friends who, have ski a lot, and they come down with A-Fib, and they had to give up, skiing, and now they're all back skiing. And it's just I think the quality of life is significantly different.
How come the lady had to have so many ablations?
So she had sort of a very difficult type of A-Fib, and one of the reasons was that she waited, it was too long. She was already in A-Fib for five or 7 years before she was sent for an ablation, and she had multiple radio frequency ablations.
Okay.
So we did advanced procedure with advanced mapping in her, which thankfully we have access to.
Nice.
And we were able to control her AFib.
So unfortunately, we won't have time to get into this, but just so the audience knows, electrophysiologists also deal with a lot of other cardiac arrhythmias too. And maybe we'll have you back to talk about some of this. But just quickly, what are some of the other things you deal with?
So, we deal with what's called supraventricular tachycardia, or SVT, which is typically in younger people where the heart just suddenly races really fast. We deal with people who pass out a lot. We deal with more advanced, congestive heart failure rhythm problems, ventricular tachycardias, slow heartbeat, anything to do with an electrical heartbeat that's not normal is sort of our domain.
And you put pacemakers into...
You put pacemakers, defibrillators, yes, all of those things.
It's amazing. Quite a bit.
Thank you.
So for someone to connect with you, they can, have a conversation with their PCP or their cardiologist, but can people also call you directly?
So typically they can, but it has to be through one provider.
Okay.
We don't typically take on patients directly just for the, because we like to work in conjunction with your doctor.
Yes.
I always tell patients, I'm a partner. This is a 3-tier system. It's your primary doctor or cardiologist, me and you. It's a partnership, because I think that there's not just one thing that brings about AFib.
Yep.
There's other things, diabetes, sleep apnea.
Sure.
We have a wellness program that we help people do lifestyle modifications.
Yep.
It's called the A-Fib Wellness Program. And that's why I feel like, this is a team effort. We are not here to sort of replace your physician in your AFib, but we are here to assist in sort of management of atrial fibrillation.
That's great. Dr. Sood, is there one message you want to leave the audience before we close?
I think as I have this corny statement that I tell everybody, as my sort of closing statement is, and the answer always is, stay in sinus.
I like it. And if you're not, you know where to go now.
That's right.
All right.
That's great to end on.
That's excellent. Thank you very much. Well, this has been wonderful.
Thank you so
I
much.
think that I'm sure everyone who will watch this is going to learn a lot about
Thank you.
atrial fibrillation and about electrophysiology and what an electrophysiologist does. And I want to thank you so much for coming and
Thank you for having me here and having this
educating our
talk.
community. And I want to thank, of course, our sponsor, Bay Coast Bank, which is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And thank you, everyone, for watching The 27th Degree with Chris and Nancy from 27 Degrees Consulting. And Dr. Sood, once again, thank you so much.
Thank you.
And I'm sure we'll have you on again at some point.
Yes. Thank you, guys. Thank you for
You're
hosting
welcome.
me.
Take care, everyone, and have a great day.